we are going to the intraocular device. So we try to discuss twisting and fish mouthing and pair and vessel stenosis and blisters and distal flow diverters. And now we are going to the hot topic of intraocular device. Whichever one you want to Tufail. And we have got the master of IST, Dr. Tufail, and he'll be covering the techniques of intraocular device deployment.
We continue here, right, Vipul? We continue here.
Yeah, you can say, then you can criticize. It's okay. So thank you very much for the invite, and I'm not the master. So we're going to go through web and contour, because these two are available, and NextEnd is available, and hopefully RTs will be available soon, and if you want, I can go through the delivery of RTs if you have time. So contour versus web, as we're going to do together. As you can see, web is this way, contour is basically sealing the neck of the aneurysm. And I think all of you, if you're going to go for intrasacral technology, don't just think about the device, think about the whole process. Think about how do you do an intrasacral device. So if you want to use RTs, you want to use contour, or you want to use a web, you should understand the basics about it. And if you see contour, you're looking at equatorial plane. The aim of the technique, often you should be, is trying to get a catheter in the mid of the aneurysm. Sometimes it's not possible. You wait for this flowering to happen, and as the flowering happens, you can then position. But in contour, what you want to do is you want to seal the neck. Okay? You place it here, it's not going to work. You place it too low, you can get into trouble, but you want this marker somewhere down there, okay? And then you can see if you do flow diversion, because it's a braided stent, you get some flow diversion in it. This is a famous man here, so I thought I should just show one of the video, as you can see. And I'm going to, from the time point of view, it doesn't matter what the patient had. You can see there is a ACOM aneurysm that you can see. It's wide neck, and you can see the neck is quite dysplastic here. You could argue that this artery is diseased here too, so you might want to, well, why do you want to do, that doesn't work like that, does it? So you can see that there is and then you can see the ACOM. What is important is try to get into that artery there, and if the video works well. So basically, like any coiling procedure, you get your best view. Here you can see what Vipul is trying to do. He's trying to access the aneurysm. You see the neck of the aneurysm. You can see that he's trying to get around. Here you can see the manipulation. In the workshop, I was trying to get everybody to understand. I always use two hands, one hand to control, one hand to push the device. Everything in neuro, if you're going to just starting, learn to control things. Here the device is being prepared, as you can see. You prepare it in the water, you push it out, make sure, like any flow diverter, any braided stent, it's the same thing that you do. And as you can see here, the device is being tested, then you put it in the back of the hub, and then obviously just ignore this. These are my designs. And there you go, you get a flush in the back. This sheet of the serous original water stripe, but this hasn't been changed. Hopefully it will change. It's quite flimsy. And then as you can see, the device is coming in. You should try and stop here, pull the device back to make sure it's attached before you start pushing in. And as you can see, it's coming in. When you deploy the device, the aim of the thing is one of the good things is that if it touches the wall, it's not as traumatic as when the web comes in. As you can see now, the device is coming in. It will start, the catheter will self-center if it needs to be. If it's touching the wall around, I wouldn't get too hassled. I've never seen a rupture with this device directly because of the device. And then you can do a very similar technique, a little bit of a push, open it, push and pull. As you can see now, it's opening up, and then, is it going? Okay. Has it stopped? and then you can see again, yeah, as he's unsheathing it. Now you have to kind of judge where you want the device to be placed. The intention of this device is to get the neck cover. The intention of the contour is to get a Y, like a Y stenting. So you come down in the neck as much as you can. Okay, so that's pretty much, I think the last part of the video I missed it, didn't I? He's very slow operator, so I haven't got that much time to show you. I think I'll have to get people to go a little bit faster. There you go. So you can see now, the device is now being come in, as you can see. And now you are coming up here, as you can see now you're crossing that marker. And then the device opens up here. As you can see now it's open completely. Now at this stage, you can see this marker is here. This is the detachment point. That's a good way you can do a CT to have a look at it. And as you can see, it's well opposed. That's quite an important point. Always make sure that the device is opposed. And now we having a Dyna-CD on the table, I think it's a very good way of making sure that you got good opposition. And as what he has done here. And then again you can see, and that it looks pretty good in all the vessels. Look at the flow. Don't get very worried about that there is some compromise. It's kind of the similar feature that RTs has. You got enough flow around the device, so you should be able to get flow across. If you think you have compromise, you can resheath it and put it a bit higher, but don't be scared to get the device low down. If you keep the device in the artery, if you don't break the flow, you will get recurrences. If you look at an ACOM aneurysm that I have treated, here you can see it's a wide neck ACOM. You can see the catheter is coming in. And if the video works, as you can see the catheter is coming in. Again, one of the benefit of this technique of this procedure is of using contour is because you're not using via catheter, which is a little bit stiffer. Sometimes when you're coming in and you're hitting on one side of the wall, you're not much worried about it because you're using Henry 721 and it's often much more softer catheter compared to the via. So if you look at it here now, let's move to the next where I can get the device in. So you catheterize like usual, get your position. Here you can see the catheter is a bit higher, which is good because you can then decide whether you want to push or whether you want to unsheath. So again here when you got quite a good access, you know you can pretty much get the device a little bit more comfortably in. As you can see, the device is getting in, and as you take a little bit of time, I always use distal triaxial system. I don't use benchmark. I think when you get into trouble, it's not easy. So don't hesitate to use triaxial system. And then you can see again now the device is being placed. As you can see now, you know that in this position you're going to be coming. Here you can see that I'm hitting the wall here. I'm going to try and now push the device. The device is touching the wall, as you can see in this projection. The catheter is going to self-center. I'm going to push it out. As you can see, the device is now getting just pushed. You'll come down, and then you can reposition you can manipulate a bit. Very important, like remember I said, when you are getting it up, you need to test that it is attached. When you detach it, you then have to expose this marker, but then you got to give a little bit of a kick up the arse of the device, because that's what we call as a stabilization test. So you want to make sure the device is stable and it's not going to move. So here you can see now the device is here, and you can then manipulate the device. As you can see now, I can manipulate the device a bit more. And I'm giving it a little bit of a push there. This push is very important when you do contours. Okay, if you don't do it, your device may not necessarily know that it is stable. Either it can move in or it can move out. And I have seen one case which I was proctoring. I forgot to tell the person to push it and give the stabilization. and tested, and the device came after the detachment into the MCA. So be very careful. As you can see now, you got good opposition. Make sure you got a wall opposition. If the device doesn't touch the wall, the device will get pushed. And then the CT. Again, in another video here, you can see the device has been pushed on this side, and you can see the opening. You can play. You can then bring it back. You got another aneurysm here. This is Vipul's case. And you can see now he's gone in. Obviously this patient has a lot of money. So you can see now, you can put another contour, and you got two kissing contours there. So you can see, and you got a stepmother in the middle, but two kissing contours. When you look at the aneurysms like these in a distal ICA, like all the cases, you can get into tricky problem because of the axis, and the catheter can jump. Height is not a problem in contour, so that's one benefit of contour when you're accessing again, because here you can see again when you catheterize, you're always going to end into the wall eccentrically. If you're going to have a web, it can be very difficult. You can see you got a nipple, you can't push. If you can't push, you'll have to unsheath and you'll end up coming out. Instead, here you know that you are safe enough, and then you can take the wire is out, and then you can see I've tried to get up across there, and let's see the web. And sorry, contour. Where is the contour video? So you can hopefully this works. And now you can see that you have managed to get it despite this very difficult access. There you go. I think this one is the video where you can see you're playing it. You're literally deploying it from the neck of the aneurysm. Here you can see, and as you will deploy it, it will fall into the aneurysm, and you know that you don't need to put a stent. You're reasonably safe from the A1. From the time point of view, I've got a web. Is that both the presentations in the same time, or? Okay, good. Okay. What you do improve, I know now, if you have got a big aneurysm, you're putting a 9, 11, 14, please try and put some coils, as you can see here. You have got a jail catheter, I've got a contour at the neck, and you can see here, you got a contour, you got a coil. These are difficult aneurysms to treat with any intrasaccular technology. So I have improvised now in what I do. I will put some coils. Okay, you may ask me, why don't you put neck stent? Because I think contour has a much more better flow diversion than neck stent. So you want to put some coils, contour and coils, and I have 2-year follow-ups on these, and they do quite well. If you have, I'm going to stop on contour here, because you can improvise it with many different, look at the wide neck aneurysms. Again, you can see, I think here again it's a very wide neck aneurysm, but you can get a contour sitting there. And you can see the contour is sitting here, and it does the job. So exactly the same thing that you can see. You got problem, but I'm going to stop from the contour because we are talking about techniques, and I'm going to go for the web presentation. Shall I just continue? Is it okay? So contour, again, I used perioperative antiplatelets. I usually treat it like a flow diverter. I will always give antiplatelets. I give antiplatelets for 4 weeks double and another 4 weeks of single antiplatelets. Web, you can do web on its own, web with a stent, web with the coils. If aneurysm looks like a web, it's good for web. If aneurysm is good for RTs, it's always good for web. If aneurysm is good for web, it's very good for RTs. That's how I look at it. The shape is very good. RTs is a bit more softer now, so it's more compliant. But you can see this is an ICA termination aneurysm. It looks like a web. And I know that I don't want to put anything else. Web will do a great job. How do I deploy a web? Here is a 71-year-old. You usually have a CTA or MRA, and you look at the dimensions on the CTA, MRA. Again, it will tell you. Again, I don't use web now in large aneurysms because I know the recurrence rates are very high. Whereas you should not be worried about putting in a less than 9 millimeter. I think the recurrence rate are a lot lower. 9, 10, 11 millimeter up, I think the recurrence rate of webs are different and higher. So here normally again, I always use triaxial system. I am probably very conservative in that way. I have a younger colleague who uses benchmark for flow diverters, benchmark for everything, but he has problem that I don't have. Okay, so in Britain everybody is different, so you don't have like the German and the French system. The boss tells you what to do and everybody does that. In Britain everybody is a boss. Okay, so I don't care who has a problem as long as I don't have a problem. So I use a triaxial system, and as you can see, there is the technique has changed, and VS17 has come in. You do, and you can measure. You've got a chart, but I don't bother with the chart because I've been using this for years. So I think now I've been using web for 14 years. The deployment is not, it's something everybody would have seen. You have a triaxial system, you got a catheter. When it is not balloon, now when it is balloon, it is soft, but when it is not balloon and it's stiff, you have to make sure you're not touching the wall, otherwise you will go through the wall. When you look at the angiogram after deployment, you can see now the device is very low and it's in the artery. But it is a very soft device, and you can resheath it very safely. You can put it back in. And here you can see after the second deployment, you can see the device is now in the aneurysm and outside. The artery is very safe here. So you can play with the device, and it's a very beautiful device in a very good aneurysm. It does a great job. In a right size, right shape, it can be a very good technique of treating aneurysms. So repositioning, you can see how it works, and it will do the job. Here is a MC aneurysm, as you can see. And it looks like a web. It's going to do a web, okay? And you can see the catheterization of the aneurysm, and then you can see you're getting into the aneurysm here. And okay, so here you can see I can catheterize aneurysm slightly faster than Vipul. But you can see, sorry Vipul, I'm just kidding. Okay, so as you can see, the catheter is on a slightly eccentric on the other end. You've got to be very careful, but it looks okay. And then you can see the web is coming in. As you can see, now you've got a web here, and you have hopefully the deployment part of it. Now you can see what you do is, again, you make sure you don't touch. If you are touching, you bring it back. You then unsheath it. Here you can see I'm unsheathing the device, making sure I'm not going to go any further. Unsheath the device, position it in such a way. Now it's a very soft device. Now you can play with it. It looks a bit forward, and then I think I can, if the video works. Okay. And here you can see now I have played with the device, and I'm going to bring the device a little bit back. It's a bit forward. I always want to make sure, because I'm always competing with the surgeons, and the surgeons don't like these small neck recurrences in UK for some reason. I did not know aspirin was a very dangerous drug, since all the younger neurosurgeons start coming in telling patients, you're going to be on aspirin for life, and aspirin is a very dangerous drug, and honestly, you have to make sure that you get good results. And I always, no offense to neurosurgery, but neurosurgeons think aspirin is the most dangerous drug, and that's why you should never put flow diverters in. But here you can see the aneurysm, and that's why you need to, if you are doing MCAs, you should get good results, because the surgeons get good results too. So I think it's important for us to get good results here. And once you are in, and there you can see the position is good. You can innovate. Here is a patient with a basilar and SCA. You could put a web here and a web here. For some reason I decided not to put two webs. And here I have decided that I'll put a web on the top and I will flow divert the aneurysm. And here you can see the web is up here. I've got 1 minute, 56 seconds. And then you can see the web is in. And you can see there is a pipeline on the other side. And I know that this aneurysm will disappear with pipeline. And Vincent correctly may ask me why I did not web. I had no answer to that question. I must have been in a mood to put a pipeline on that day, but I think you could have easily done a web in that. So I think you're correct. I think that was a misjudgment on my call, on my behalf. So acute, I think it's a brilliant technique. Here is a large hematoma, big aneurysm. Surgeons would love to clip this, and we can put an endovascular clip, as you can, I'll show you in a minute, where you can see large aneurysm. I usually show this in neurosurgical conferences because that pisses a lot of people off, but in a nice way. But you can see I've got a jail and I've got a web, and you can see you can put a web here and then you can coil the aneurysms. So you can innovate with the technique. Well, what is important is to see whether it stays like that in the long term. Sizing is an issue. If you see now Web 17 is beautiful, it's soft. You can put it in benchmark, but it is very soft. And there you can see there's the device was put in by one of my colleagues who doesn't put a lot of web. And this is the problem. The problem is you should do enough to know that you can anticipate that this is an undersized web. What happens as soon as you detach it, it has turned into other side. This is not a device problem. This is operator problem. Okay? And this is why devices get bad name, because that was undersized device. So please, if you don't do enough, make sure you have people around you who will know what to do and give you that opinion. And the opinion is there. I'm going to stop here because I think I can show you trouble. But both the devices will have problems. Thromboembolic, with web, I know it's 14%. With contour, I know it's about 14, 13, 14. That's a ballpark figure. Symptomatic is around 3 to 5%. So symptomatic is small, which is why I give perioperative antiplatelets. Because I know that I get thromboembolic. I do get thromboembolic with contour too, because I come down into the neck, okay? And you have a braided device, so I give it. But we have done so many webs, and we know that you get thromboembolic. Delayed recurrences, you're going to get both. A complete occlusion in both the technique, both the technology, I think it's around 60%. At least with contour, I know it's 60. Adequate occlusion with contour is around 85%. So why do I need to know this? When I tell patients, I have a figure to give them. And I think that's very important. When the surgeon asks, when we're debating, I have a figure, what my occlusion rate is. And then you can put that into practice according to what patient you're going to treat. Thank you. Anybody wants, do you want to see RTs as well? Am I in time?
Thanks, Tufail. So before you go to RTs, or you may not go to RTs, there are a couple of comments that I will make, which is for our geography. And that comment is about the sizing. You're very, very right in saying that if you undersize, then aneurysm is just going to come back. So what happened is, a few years ago, there was a euphoria of the fastest 100 contours that was happening in India. Very quickly, 100 and over 100 contours were deployed. And maybe quite some of them were undersized, because now, if you're doing follow-up, or if the patients are coming back to you, then there are quite a bit of recanalizations. And I think those were related to not sizing it properly, undersizing the device. Number two, the second point that you made was, whenever possible, if the aneurysm is sizable, whenever possible, jail another microcatheter and put coils. I think that was not done at all in the initial, those first few hundred cases here. And now we are wiser, but those cases have been done already. And that is another reason why it is not the device, but it is just that we did not know enough. We just went ahead and deployed devices right, left, and center. The second point that I will make is about the next stents. You hardly showed any cases about next stent. So because of the happy euphoria on contour, we have deployed in India quite a bit of next stents also. Personally, numbers are not large, but personally, the next stents are always with coils. So the anterior circulation next stents have done much better than, say, the basilar top next stents. I mean, we have done 2 or 3 basilar top next stents, all of them have recurred badly. So any comment on that?
Yeah. I mean, there is a learning curve with everything. And, what you're describing, I have been always lucky to start early, so I have more screw-ups than many people. And I totally get that, what you're saying. If it's undersized, you're going to get into trouble. Now we know that 9 millimeter up contour is a problem, but we've been through that learning curve for web also. We are 12 years, or 2012 I started web. So I know now when not to web. I know now when not to contour or how to contour. You are absolutely correct about next stent. Again, now next stent, I have the largest follow-up in next stent. We just recently analyzed our 2-year follow-up data, and next stent, but I coil completely as if I'm coiling. Now I have had recurrences, and basilar is a very difficult, basilar top is a very difficult place for us to get complete occlusion in many techniques. So I think when it's a large aneurysm, unless you flow divert or stent it, if it's a large aneurysm with next stent, if it is still next stent is not sitting on the wall, don't put it. And what happens there, and I coil completely with next stent, okay? With contour, if it's again, if it is undersized, you got a contour which is say 14 millimeter. The largest contour is 14 millimeter. You can only treat up to 10 millimeter. So it's never going to sit on the wall. Don't put it. Okay? It will look beautiful when you finish it. But I can tell you in 6 months' time, it will be in the aneurysm. Now, does it matter when it's an acute one? I don't think it does, because you protect it and you can come back and flow divert it. So I've had recurrences in basilar, and initially the whole euphoria about single technique, single device, I think it's a misconception. I don't think we should think about taking a device and just putting it. We need to understand the pathology of some of these aneurysms. The disease is in the wall. Despite the best size, still, like web does, and I know we're going to have the same problem with RTs, even if you size properly, even if it looks perfect, you will still have some recurrences, because the disease is such that the wall is diseased. And the surgeons have been knowing this for years. If you flow divert, all of them will do well. But the complication rate of flow diverter in a posterior circulation is quite high. So I think you are in an acute, you are not going to put a flow diverter. You can web or contour a coil, bring the patient back and treat it. And I think that's quite a reasonable approach.
So Tufail, you mentioned about criticality of sizing. Now there are a lot of youngsters here, and sadly, even among seniors of us, I don't think we have gotten over a learning curve. You have to do quite a few. These are costly devices. So can you, very short time, can you say what are the precautions to be taken, sizing of web or contour? I mean, any message you have?
So if it's more than 10 millimeter, okay,
Yeah.
don't use web, don't use contour. 9, 10, 11 size, once you got that level, your recurrence rates are very high. Acute, yes, no problem. Same with contour. Once it goes to about 8, 9, 10 millimeter aneurysm and a 14 millimeter will work, use coils. Sizing for web, my technique is, and I've been doing it for years now, I'll do the 2 planes. I will add, I don't need the chart, I do the 2 planes, I add it up, divide it by 2, plus 1, and then I'll decide the height. That height decision will depend on my access, depend on whether it's an old patient, but I try to fill as much as I can. With contour, the rule is 2 millimeters on either side. So if you got a neck which is say 5, I want to go 6, 7, 8, 9, I need a 9. But then if it is height is enough, it's okay. But the height is not enough, then I might go for a 7. The thing is, if the aneurysm is bigger, if it is more than 9 with contour, if I'm using contour, I will use coils. You don't use coil, I'll tell you what, in 2 years, you're going to get those recurrences because I've seen them. Some of them, especially basilar top, I think it's notorious and we should be struggling with that.
So Vincent, what about you sizing these devices? I know you could do quite an intracellular device and I think you have a different approach altogether.
Yes. The difference rely in the sizing technique. We are also doing a lot of intrasaccular treatment in Montpellier. For example, out of the 400 aneurysms we are doing per year, 100 is intrasaccular per year. So we are, and we were the first user in France. I mean, the third generation. So it's a long time we're using intrasaccular in Montpellier, and we make up our mind that the sizing was a key point. And the flowchart provided by the manufacturer is highly, in my view, cannot cover the complexity of the shape of the aneurysms. Even if you take AP view, lateral view, I mean, you are missing the complexity of the shape. So it's a good approach to embed. But Tufail is sizing well because he has 15 years of experience in the field and so he finds a good size. But if you not have 15 years of experience, I mean, it could be difficult to size well. And the problem is that we don't have time, but I can show you, just published an article that is been accepted in the Genius, that the sizing, improper sizing is a risk factor for compaction. And what is amazing is that the mechanical characteristic that is a compression, mechanical apposition to the device to the wall, that you can only sort out with simulation, is an independent risk factor for recurrence. So what we are doing is that we are sending the 3D anatomy in simulation software. I will illustrate you in a few minutes a case, just an example of how we are doing in a daily fashion in Montpellier and in other centers right now in the world. So we are putting the 3D into the machine, and we have the 3D representation of the sac. Then we are selecting the wave according to parameters, the parent artery bulging, the apposition, but also now the compression, especially with the artist. Now we have the compression parameters, so we see how much intense is the force of apposition of the implant to the wall. So then I just look. I do not anymore. Since the last 7 years, I never did anymore any 2D measurement on angio for sizing and intrasaccular, just on the computer. And then I select according that. And then the rate of change web per procedure is 1.02, meaning that we almost never change the web during the procedure. And I do the same now with the contour. I size with the software. So I think for me, I have to disclose that I have a conflict of interest because I'm co-founder of Sin and Size, so to be clear. But out of that, I truly believe it's the next step. That's why we work on that, but actually it's the next step. We will size properly, and the more complex are the implant, the more need you have to size. The coils, we were not really in trouble because you can put like 4 different sizes of coil. Sometimes it's enough to pack the thing and just continue coiling, so there was no really need for sizing. But now you are doing with complex things, flow diversion, contour, artists, etc., and more complex, and then you need to size. So for me, it's computer-driven.
So Tufail mentioned he does his measurements himself and takes a size, but then needs a lot of experience.
Vipul.
And
Sorry, do you want to ask my technique of sizing?
and I'm just summarizing. And Vincent mentioned he used softwares to size, and Uday, he has a smile on his face.
Yeah. So
Uday, how do you size?
A very, very simple technique of measurement. We just ask our microvention guy. His name is Sundar. So the size is his. If it doesn't go, the next device is on him. It's
So
very simple. We don't have.
and Uday said something very practical, and we don't have software, we don't have the experience. So industry has to use the experience of more experienced operators to get us the size, and so that we are not responsible for wasting a device. And last thing, I want to use a costly device and have a recurrence in a short while. So which is a challenge. So, but I think intrasaccular devices are here to stay. And the challenge is getting over the learning curve in our circumstances, because even now in my department, rupture aneurysm, coiling is a very powerful, simple, straightforward and much cheaper technique, and major block is actually expenses. And then since because we are not using that many, we get reluctant to use more. But I think they are here to stay. The technology is getting better. More are coming into the system. So all of us need to get over the learning curve. That's all I can. Just last question to Tufail. You showed a case like a reverse pointing ACOM, your microcatheter hitting the wall, and then delivering a device. And I find that very uncomfortable at times. I've done it. So how do you manipulate in that circumstance? And you showed it very well, that you push out the device and then it repositions itself. Just go over that in 1 minute or 2 minutes.
Yeah, so...
when funnily pointing microcatheter, how do you get the device right into the position, whether it's web or contour?
Yeah, so I think web is very difficult in that location now. What happens is that you are, even with the VR goes on one side of the device, of the aneurysm, and you try to unsheath, you'll end up being outside and it's difficult to position. What I do sometimes when I'm using web is once it's soft, you start unsheathing it, but once it is soft, you can use the device to get deeper into the aneurysm and then unsheath it again. But you need a little bit of a height in that to play with the web. With contour, what happens sometimes, contour is not a problem touching the wall. But in those eccentric aneurysms, contour doesn't open very nicely because it remains eccentrically open and it doesn't open. What I have recently learned, and I think intrasaccular technology is getting better, and I did a case exactly what you're describing. I couldn't get a web, I couldn't get a contour, but RTs just moved in. Because the way RTs behave, it's softer. And it conforms a little bit more better. So it had the beauty about web, but the softness of the contour. And it mixed them both together to get yourself in those forward pointing, eccentric anterior ACOM aneurysms. So I think when and this is the important thing when you know intrasaccular, because I can look at an aneurysm now and I can tell I'm not going to get here with the web. So I think that experience is important. But it's a very difficult thing to translate that into everybody else, because if you don't do much, then you are in trouble.
And sometimes people think, okay, it's pulling a microcatheter, delivering a device, but there are techniques to it. You need good angiographic system to see it's touching the wall or you're turning around this thing, and whether newer device will be easier to use in that situation. Just last question, how much bulge into the parent vessel you want and why do you want it?
So the bulge in the parent vessel with contour or RTs I wanted is because I think you have to disrupt the flow in this terminal ICA or basilar termination. Why we are successful with Y stenting or T stenting is because the flow is disrupted into the aneurysm. If you believe Shivan talks about this pivotal point at the neck of the aneurysm. I don't know whether you've heard of him. And he always talks about the pivot point at the neck of the aneurysm, why you should disrupt the flow. And I think I want contour very low because I can disrupt the flow. I'm not worried about giving antiplatelets, and I'm not worried about coming down into the neck of the aneurysm. So you use contour, please come down in the neck, construct a Y stenting, but through the aneurysm. That is the philosophy.
Yeah. All right, great. Thanks a lot, Tufail, and let's give him a hand. I mean, it's a long talk he has taken and prepared. He has been there for 3 days, very, very busy.